So today is the third presentation we're going to have about experimental epidemiologic study designs. But there's an important difference between what we're talking about today and what we've talked about the last two sessions, which is that in the last two sessions we've talked about experiments in which we randomly assign individuals to one group or another. So we randomly assign people to be vaccinated or not vaccinated, get drug A versus drug B, get a health intervention, not get a health intervention. But individual people are the unit of randomization and the unit of analysis. And as this slide says in way too many words for a PowerPoint slide, I apologize. What we're talking about today are experiments in which it's not individuals, but groups of individuals who are randomly assigned to one exposure category or another. So groups are the unit of randomization. Groups, therefore, are the unit of analysis. And it's an important distinction to get right because the statistical methods for planning the study, for calculating the sample size, for analyzing the data are different when you randomize groups than when you randomize individuals. And it's astonishing, based on what's in the literature, how frequently people screw this up. Okay? So it is still very common to see people publish studies or to propose studies in which they fundamentally decide they're going to randomly assign two groups. Town A will get something, town B won't get something. And if each of the towns has 1,000 people, they think their sample size is 2,000 people. Technically, their sample size is 2, not 2,000. Okay? Because they're randomizing groups, not individuals. And so this is a very common study design in public health for reasons that you'll see. And for reasons that befuddle me, people continue to get it wrong. And there's really no reason for that. So what types of interventions might we want to randomize groups rather than individuals? Well, very, very commonly, it's some educational message, something to improve nutrition or to prevent or get people to stop smoking, something about alcohol or drug abuse prevention, something about improved, safer sexual practices, hygiene and sanitation, et cetera. So many health education messages for those who are in behavioral sciences. Environmental change, so providing clean drinking water, digging wells, providing latrines, things of that kind. Mass treatment of large parts of the population to either treat or prevent a disease. Vaccination studies are sometimes done randomizing groups rather than individuals. Family planning, nutritional supplementation, fluoridation of water, cash transfers in order to see if giving people money in some way improves their health status. Any of these might be appropriate for studies in which you would randomize groups rather than individuals. And groups can sometimes be cities or towns or villages. They can be work sites such as factories or companies. They can be schools or daycare centers or healthcare delivery sites or households. But fundamentally, they can be large or small clusters of people, but they are clusters of people, not individual people who are being randomly assigned. Okay, so, sorry. This points out the challenges with doing group randomized studies. So the overwhelmingly most important issue is it won't surprise you to know that people who are in a group tend to be more similar to other people in that group than they are to people in other groups. Whether you're talking about households or villages or whatever it is, there is basically a correlation that exists among the people within a group, and that therefore they are really not, if you will, independent observations. And so this basically speaks to the fact that, again, two cities with 10,000 residents each, if you randomly assign 10,000 people, one city to one group and one city to another group, it is not the same as randomly assigning 20,000 individuals, half of them to one group, half to another group, because the people in each city tend to be more alike with each other than to people in the other city in this case, right? So that's what we refer to as the design effect. And that design effect basically means that the effective sample size here is much less than 20,000. It might not be 2, but it's much less than 20,000. A second challenge with doing these studies is in terms of expense and administrative and bureaucratic and political obstacles, it may be very difficult to randomly assign large numbers of groups. 10, 20, 30, 40 villages or cities might be a real challenge to randomize in terms of all of these types of issues. Thirdly, as I'll show you, there may be secular trends in the outcome of interest that are unrelated to the intervention and may make it difficult to assess the impact of the intervention. I'm going to show you an example of that. An interesting ethical question: who can provide consent on behalf of a city? Who can say that Oakland will participate or that Village A in Tanzania will participate in a cluster randomized study? Who has the authority to give that kind of permission? And if someone does give that permission, are you still obliged to get individual level consent from everyone in the cluster or the village or whatever? And then, of course, there are obviously circumstances where randomization may be either politically or in some other way impractical or not possible. So given those problems, why would we want to randomize groups instead of randomize individuals? What would be our motivation for choosing a cluster randomized design instead of an individual level design? Can you think of a reason why, despite some of these problems, we would persist and still want to do that? Yeah. It may be less expensive, so it's possible that randomizing groups will be less expensive than randomizing individuals, or keeping track of who is in which group may be less expensive. Sure, that's possible, yeah.
There's some interventions that only act on a group level, right?
Like, give me an example.
You build a well in one village and not in another. You can't really randomize certain people in that village.
So there may be interventions that we can only supply at the group level, and it's simply impossible to supply to individuals. And I'm going to show you an example of that, although it isn't providing a well. In theory, I could provide you a well and not provide your neighbor with a well, right? In theory. But in practice, what's the problem with that? Suppose I randomly assign people to get a new well or not get a new well. It might be more expensive, but in theory I could do that. But what's the other problem? Sorry, louder.
Socially impractical?
Socially impractical, meaning what?
I think you cause more effects than just not providing someone a well. If you're providing a neighbor with a well and not allowing them to.
So you mean it might create friction or anger or things like that? Is that what you mean?
Yeah, and just end up with worse outcomes than the whole village.
Okay, so it's possible it might have adverse consequences. What else? What's the other real problem of doing that? Suppose I randomly assign you to get a well, and your neighbor not to get a well.
You might want to share your well with your neighbor.
Duh, right? I mean, you know, if your next door neighbor has a new well, and you have the choice of going to your neighbor and saying, "Can I have water from your well, or I'm going to keep walking 5 miles to the river to get a bucket of water," which am I going to do? Right? So it may be possible to randomize individuals, but in practice, there's going to be an enormous amount of what we would call contamination. That is, that people will share the resource, right? Or if it's information I'm providing about behavior, some sort of behavior change message, what's to keep people from talking to each other and sharing that message, right? So that would be another example of contamination, if you will, where in theory I could provide information to some individuals and not to others. But in the real world, people talk to each other, right? And they share information, right? So those are certainly some of the key reasons we do it. There are a couple of others, but again, perhaps the intervention can only be applied at the community level, such as vector control. I'll show you an example of that. Maybe it's logistically easier in terms of cost or administration or political reasons to do an intervention at the group rather than individual level. Maybe it's this issue of minimizing cross-contamination, people sharing information or sharing a well or something. Sometimes the effect when applied at the community level may in fact be different than the effect when provided at an individual level. So for example, if I randomize people to get a vaccine or not get a vaccine, and the infection is spread from person to person, if I have 90% of the population vaccinated, I will get both potentially direct effects in the individuals who get the vaccine and what are called indirect effects, sometimes called herd immunity, where there's reduced transmission because virtually everybody is immune. You won't see those effects if you randomize individuals. Okay? So in my line of work with vaccines, this is sometimes an issue. But often, we may know that an intervention works at the individual level, but it's totally too expensive to continue to do it to people individually, and we want to know if doing it to groups of people, which is cheaper, will accomplish the same thing. So there are a number of reasons why we might want to randomize groups. Now, when we randomize groups, it's important to point out there are various outcomes we can measure. Sometimes it's the incidence of some disease or infection, like malaria or HIV infection. Sometimes it can be observation of behavior, such as seatbelt use or hand washing. And the problem, the good thing about simply observing what people do is it's fairly easy, and it takes a smaller study to see if people change their behaviors. What's the disadvantage of only measuring behaviors? So the advantage is it's easier and it generally takes fewer people in a study, but what's the disadvantage of only measuring behaviors?
You don't necessarily measure outcomes, but health outcomes.
Maybe people change their behaviors and there's no impact at all on the disease we're trying to prevent, in which case we could show an effect on behavior that's of no public health benefit, right? So in general, it's harder and takes bigger studies to show an effect on the rate of disease, but that's ultimately what we're most interested in. Sometimes we can just collect information about self-reported behaviors. Here you have the same problem, in addition to the fact that people may not give you correct information. And of course, we can sometimes observe structural or environmental changes, such as something like availability of healthy food choices in a cafeteria. Now, when we try and figure out how we're going to assess what's going on, there are basically two approaches. One is longitudinal follow-up of individuals within these communities, what we're going to talk about next Monday in terms of cohorts of people within these communities, and looking at the rates of disease in individuals, these cohorts. Sometimes we can do repeated cross-sectional studies in these communities, and sometimes we actually do both. Okay? This idea of following individuals as a cohort within these communities, the advantage is that with the same sample size, we'll generally have greater statistical power than repeated cross-sectional studies, and this has to do with the sampling error being reduced. The disadvantage is if we continue to ask the same questions or look at the same people again and again and again over time, that observation process may change those individuals and make them different from the other people in the community, less representative of the other people in the community. And so, therefore, they may become unrepresentative of what's going on. And of course, there also can be attrition, and to the extent that people who drop out are different from the people who stay in that cohort, we may get a biased answer, and those are types of biases we'll talk about in a few weeks. These repeated cross-sectional approaches, the advantage is that given that the primary aim of a community intervention is to promote change at the community level, repeated cross-sectional studies may be considered the more appropriate measure. On the other hand, the problem is that these repeated cross-sectional studies may include individuals with limited exposure to the intervention due to in-migration, and we frequently can't really judge what the reasons for a lack of change within individuals are by doing repeated cross-sections instead of following people over time. So given the resources, we frequently do both, okay? But they each cost money. So I'm going to show you several examples. We may not have time for all of these. The first one I want to show you is the COMMIT study. The community, first thing is whenever you do an epidemiologic study, you need a cute acronym, okay? So you'll notice lots of cute acronyms like Mr. Fit, the multiple risk factor intervention trial. Here we've got the COMMIT study, Community Intervention Trial for Smoking Cessation. People spend inordinate amounts of time figuring out cute acronyms. And so this study was basically asking the question, could a community level intervention get people to quit smoking? Okay? Now you could envision randomizing individuals to some sort of smoking prevention activity and seeing if it works, but that's pretty costly. And so here the question was, could you do this at the group level and have some impact? Okay? And here's an example where this question of secular trends is really important, right? That is, if you're doing this in a context where smoking behaviors are changing in general, if you just did a before-after comparison, we've got smokers, we go in and do whatever we're going to do, we measure smoking afterwards, people quit smoking, hooray, it was our intervention. Okay, a before-after comparison may be entirely due to other things going on that has nothing to do with our intervention. So it's really important to have contemporaneous comparison or control groups because of these secular trends. So here, they were interested in seeing if this intervention would get smokers in this age group to achieve and maintain cessation, the highest priority on heavy smokers. So they took 11 matched community pairs, so a total of 22 communities altogether, and they randomly assigned 11 communities to get the intervention and 11 communities to remain as controls. Okay? And they matched the communities on geographic location, size, and what they call general socio-demographic factors, whatever that means. Okay? So they basically did both. They followed both cohorts and did cross-sectional studies. So how did they do this? Well, they did telephone surveys to look at the baseline prevalence of smoking. They identified cohorts of smokers to follow over time within these communities. And then they calculated the quit rate. What proportion of smokers quit over time? Okay, that's the outcome they're interested in, people quitting smoking. And so what was the intervention? And could you do these things to individuals? Does it make sense to talk about randomizing individuals if this is your way to get people to quit smoking? So there are public media campaigns, there are kickoff events, there are all of these things going on in public education. There's a lot of training of healthcare providers, promoting networks, all of these sorts of things among healthcare providers. At work sites, they're doing presentations, offering incentives and materials, and all kinds of resources. So could you envision doing this to individuals rather than the communities? It's ludicrous to even think about, right? You couldn't possibly, if this is what your intervention is, if this is what you think is to get people to quit smoking, it doesn't make sense to talk about randomizing individuals. You have to think about randomizing communities, right? And it's important. If this works, we'd really like to know it. And here's the bad news. So here are the quit rates. So this is what proportion of smokers quit. And down here, up here are the light and moderate smokers in the cohorts of light and moderate smokers. Here are the heavy smokers. The black are the intervention communities, and the white are the controlled communities. And what you see is that in both communities, a lot of people quit smoking. That's really good news. But there's absolutely no difference between the communities getting this super-duper intervention and communities not getting the intervention. So presumably these people who are quitting because of other things going on in the community. Had you only done a before-after comparison, if you taken 10 communities and done all this stuff and found these quit rates, you would have claimed credit for all these people quitting smoking when you deserve none of the credit whatsoever, because it's entirely due to other things going on in the community. So the fact that there's no difference between the intervention and comparison communities basically tells you that this intervention failed. Okay? People are quitting, and that's great, but it's not because of this intervention. And here you can just see they also have, so they have the prevalence of smoking. And they do different cross-sectional studies of smoking, heavy smoking. They look at quit ratios. Fundamentally, these communities are identical whether they got the intervention or whether they didn't get the intervention in terms of how many people, what proportion quit, what the prevalence of smoking was, etc. So I won't go into the details here. Now what's important to point out is they knew what they were doing, and what they did is, if you remember, they had 11 pairs of communities. And when you do these studies right, each of those pairs is considered a stratum. Okay? So altogether there are 11 strata in this study. When you come to analyze the data, you analyze each stratum individual. So this is pair number one. Pair number one has an intervention community and a control community. Here you can see this is the cigarette smoking prevalence in the intervention community at the end of the study. Here it is in the comparison community, and here's the difference. So it's just that doesn't look. So this is the difference in what proportion quit or the change between baseline and the end time. So the difference between 7 and 4.8 is this should be, I guess, 2.2. So that's the difference. You do that for each of the 11 strata, and then you have statistical means of summing these and coming up with an overall effect across the 11 strata. You don't just take all the data from the 22 communities and throw them together. You analyze these as 11 pairs of communities. And there are statistical methods for doing that are beyond what I'm going to talk about. And what you basically see when you average these across the 11 strata is that basically there was no difference. Okay? But this is the correct way to take data from a study like this when you have these pairs. Okay? And you can see the program, the conclusion was it didn't increase smoking quit rates. Now, this is an example of one of the best studies of this kind that I'm familiar with. So I want to show you what an elegant community randomized trial looks like. So here, this is the question is, the concern is childhood diarrhea in poor countries. People started out with what are called qualitative studies, going in and looking at what are the behaviors people have. So you simply go in and talk to people, you watch people, and you see, for example, that many mothers don't wash their hands before preparing a meal, or that children defecate in the open in the yard. So you look at various behaviors. They then did epidemiologic studies to see which of those behaviors actually correlated with the risk of diarrhea in a child in the household. And they found certain behaviors increased the risk of diarrhea, others had no relationship. And they developed a health intervention program targeted at those things associated with a higher risk of diarrhea. Okay? And then they want to know whether that works. So the outcome of interest is diarrhea in children in the house. So they found in their based on their qualitative study and their analytic epidemiologic study that there were 3 risk factors for childhood diarrhea in these communities. One was children openly defecating in the living area of the household. The second was lack of mother's hand washing before preparing food. And the third was not properly disposing of garbage and feces. So these 3 things correlated with a child's risk of diarrhea. So they developed a behavioral intervention, an educational program to educate moms about these 3 things. Could you randomize individual moms within a community and educate half of them about this and not educate the other half? In theory, yes. In practice, no. Because women who are in the same community presumably will talk to each other and share information, right? So it's simply not plausible. And so when they started their study, they first of all, very importantly, collected a lot of baseline information about they randomized 51 communities, and for them a community was a cluster of around 40 families living in contiguous households. They define a family as people residing together sharing the same cooking pot. So they've got 51 of these communities. They start out measuring the rate of diarrhea in children in these communities. They then rank the communities from the highest rate of diarrhea to the lowest rate of diarrhea. So they've got them ranked 1 through 51. They take the top 2, the 2 with the highest rate of diarrhea. They make them a pair, a stratum. They randomly assign 1 to the intervention, 1 to the control, and they do that 26 times. So they end up with 26 pairs. One pair only has 1 community. I don't know why they didn't just stop at 50, but they didn't. Okay? So they've got 25 and a half pairs, 25 and a half strata, and then they do their intervention in half the communities. They don't do the intervention in the other half, and they measure rates of diarrhea. Right? Pretty simple. Okay? But again, the critical issue is, what have they done by this approach in terms of the rate of diarrhea? What have they guaranteed by taking this approach to creating pairs? Why did they go to all that trouble? What did they guarantee by ranking the communities by rate of diarrhea and then taking the 2 highest and making them a pair, the next 2 a pair, etc.? What did they guarantee by doing that? That the rates of diarrhea in the intervention communities and the control communities were identical at baseline. Right? And that's obviously why they went to all that trouble. If you want to measure diarrhea, by the way, it's really important. You basically have to make at least household visits every 2 weeks. Better is every week. You might think it's easy to figure out who has diarrhea and who doesn't. When an episode of diarrhea begins and when it ends, it turns out to be challenging to actually do this. What the definition of diarrhea is actually not so straightforward either. But what I want to point out here is that these people knew what they were doing, and so here's the analysis section. Because clusters of individuals rather than individuals per se were the units of randomization and hence the appropriate units of analysis, we compared incidence rates of diarrhea of the intervention and control communities according to the matched pair strata, treating the incidence rate of each community as a single observation rather than a group of observations. So what that means is they have 25 pairs. For each community and each pair, they have the incidence density rate of diarrhea, right? So what can they calculate for each pair of communities? For each 2 communities, one a control, one an intervention, they've got the incidence density rate for each community. What can they calculate with those 2 incidence density rates? They could subtract one from the other and get the rate difference, or they could divide one by the other and come up with the incidence density rate ratio, right? Because epidemiologists tend to prefer rate ratios to rate differences. They chose rate ratios. You do that 25 times, and then you average those across the 25 strata, okay? That's the right way to do a study of this kind. So here you can just see they've got information about these 51 communities, and they basically can prove that they are demographically identical, that their baseline behaviors with regard to feces and garbage and everything else are identical. There are no differences at baseline between these communities, and they establish that. And so here now are the data from each stratum. So this is the intervention community, has a rate of diarrhea per 100 person weeks of 2.0. The control community in this stratum has one of 1.2. The incidence density rate ratio is 1.7. And they do that for all of the strata. And then they average them and come up with an overall mean incidence rate ratio, right? And that is 0.75. And the simple-minded interpretation of that 0.75 is what? If you had to explain to your mother what that means, what does that mean? Did the intervention work? Didn't? It worked. How well did it work? So the intervention communities have a lower rate of diarrhea than the control communities. How much lower? 25% lower. The rate ratio is 0.75. It's 25% lower, right? The intervention worked. Now, if you ask, if I come back a year later, will I still see a difference in the rate of diarrhea in kids? Who knows? The study didn't do that. So will this educational message persist? Will it have lasting impact in the communities? The study is silent on that question. But during this intervention period, the rate of diarrhea was 25% less in the intervention communities than in the control communities. And they were identical at baseline with regard to all the factors you might be interested in, including the rate of diarrhea. Okay? But again, they took these 25 pairs, treated each pair as an individual stratum, and calculated a rate ratio for each of the pairs, and then averaged them. This is the right way to do this kind of study. Okay? And here you can just see this is basically the same thing. You can also look at total episodes of diarrhea, total number of weeks of observation time, etc. But this calculation of the incidence density ratio is done taking into account the way in which these pairs were created and the fact that these are community interventions, communities randomized, not individuals. And here you can just see they look at it by different age groups. And the effect is primarily in the youngest kids, but there is an effect pretty much across the under 5 range. Okay, and they concluded that they basically saw during the 6 months after the intervention, the rate of diarrhea in kids under 6 was 4.3 compared to 5.8, a 26% protective efficacy, suggesting the intervention worked. Okay. Now, here's another very important example that relates to HIV/AIDS. Frequently, you can imagine you don't have 50 communities to randomize. That's a pretty big deal to randomize 50 communities. You can do the right study design with far fewer communities. And so here the issue is, again, you all know that HIV is a major problem in sub-Saharan Africa. Some communities in sub-Saharan Africa have a prevalence of HIV of over 30% in people of reproductive age. A third of the population infected with HIV. No HIV vaccine. And studies showing that failure to treat other sexually transmitted infections like gonorrhea and syphilis facilitates heterosexual transmission of HIV. Many, many studies showing that gonorrhea, syphilis, herpes, various other STIs increase transmission of HIV. And there are biologically good reasons why that makes sense. Okay? And in Africa, if you don't know, many communities, most communities don't have access to good treatment of sexually transmitted infections like gonorrhea and syphilis. Okay? So here the question is, if I improve treatment of sexually transmitted diseases, will I reduce the incidence of HIV infection? Okay? Does that seem like a reasonable thing to know? So could you randomize individuals and get the answer to that question? Who said no? And why not?
One group would get information, one individual would share the same information.
Well, this is not so much, this isn't information. I'm going to treat you if you come in with your syphilis. I'm going to treat you if you come in with your gonorrhea. I'm going to treat you if you come in with your chlamydia. So a huge piece of this is diagnosing the other STD and treating it. It's not so much a question of it. Yeah, information is part of it for sure. But the key issue is correctly diagnosing and treating other STDs. So could I do this by randomizing individuals?
Well, I mean, on some level, no, because they're having sex with somebody else, and if that other person isn't getting the intervention.
Well, I'm not sure that's the problem. After all, we can give what's called partner-delivered therapy. If we treat you, we can give you some penicillin or whatever it is, not penicillin usually, to give to your partner. In fact, my wife changed the law in California so doctors could do that. You could do that in other countries as well. So I'm not sure that that's the primary problem. I think your answer is right, but for different reasons. Yeah.
It's sort of like the EPA experiment. If you weren't treating people who had syphilis.
So first of all, would it be ethical to not treat some people who are identified as having a treatable sexually transmitted disease? That's totally unethical, right? So the whole thing is ludicrous in terms of the ethics, right? But it also really wouldn't even answer the question you're interested in. The question you're interested in is, if I improve STD diagnosis and treatment at the community level, will that have an impact on transmission of HIV within the community? That's really the question. So not only is it totally unethical, but I don't even think it really would answer the question that we're that interested in. Okay? So these people intelligently chose a cluster randomized design. Okay? And this was done in northwestern Tanzania. This is called the Mwanza study. Community-based randomized intervention, and here they didn't take 50, they took 12 communities, and they randomly assigned 6 of them to have their STD diagnostic capabilities and treatment capabilities improved, and 6 of them to continue to have whatever they had before. Is that ethical? If what they had before is terrible? Plenty of IRBs thought it was totally ethical. You may have your issues about it, but it was certainly judged to be ethical to do this. Okay? And so the exposure of interest is, does your community have improved STD management or not? The outcome of interest is the incidence of new HIV infections among people of reproductive age. And in order to figure out what was happening, they chose random individuals among the communities and HIV negative at baseline. And they followed them over time and looked at the rate of HIV infection in these individuals within each of these 12 communities. Okay? So this is looking at, this is the cohort approach, not a cross-sectional approach. What did they do in terms of the intervention? They established an STD reference clinic and lab. They trained the staff in how to diagnose and treat STDs using various WHO algorithms. Provided condoms, etc. They provided the drugs to treat the STDs. They did supervisory visits, etc. And the villages that didn't get this had whatever was there before, which wasn't much. Okay? Yeah, sorry.
Who provided the consent for?
Who provided the consent? It's a really good question, and I don't remember. So I'm going to show you the reference at the end, and one of us can go back and dig it up and see what they say about who provided consent on behalf of the village. But I think you know that in many cultures, the village head, the village chief, is generally thought to be empowered to consent on behalf of a village. Okay, so I don't know if that's true in Tanzania. I don't know if anyone here knows the situation in Tanzania or in Mwanza, but there are many places where that would be judged entirely reasonable. But it's a good question. I honestly don't remember. Okay, so they take 12 communities and they match them into 6 pairs according to location: roadside, lakeshore, island, or rural. Okay, and in each of the 6 pairs, they randomly assign one to the intervention group and randomly assign one to the control group. Okay. So they've got 6 pairs. This is Tanzania, I guess, looks like. So here's a better map of Tanzania. And Mwanza's up here on Lake Victoria. Okay, like that. Okay. And so here you can see the town, and here's where the different communities were. And so each number, this is one pair of communities, this is another pair, this is another pair. And obviously a critical issue in doing this is knowing enough about these communities to know who travels where, lots and lots of social interactions in terms of trying to decide what are the right pairs to choose, okay? And that can obviously be fairly complicated. And again, these people knew what they were doing. Since randomization was applied at the community level, statistical inference needed to take account of between community variations in incidence. Within each matched pair, the risk ratio of the HIV incidence in the intervention community relative to the comparison community was calculated. So in other words, they're going to calculate 6 risk ratios, right? 1 for each stratum. And then they're going to average them all across the 6. Okay? And so here you can see the baseline prevalence of HIV and other STDs, men and women, the intervention communities, the comparison communities, generally showing that the communities were comparable at baseline. This is a critical piece of any study of this kind, showing the communities are comparable at baseline with regard to the things you're interested in. And here are the incidents, the cumulative incidents for women and for men in different age groups. The white are the intervention communities, the black are the comparison communities, and what you basically see is that in each age group, in each gender, the incidence of HIV infection over the next 2 years was lower in the intervention communities than in the comparison communities, although in this group, obviously, there really wasn't a difference. But in all the other groups, a pretty substantial difference. So that's the graphic representation. Here are the actual numbers for each pair intervention community in terms of HIV infections. Intervention comparison community, crude risk ratio, adjusted risk ratio. They've got 6 of them. They can average them together. The intervention worked. The intervention worked, and it reduced the rate of HIV infection about 40%, right? The risk ratio is 0.58, about a 42% reduction in the risk of HIV infection, right? So another example, this time it only took 12 communities. It didn't take 50, it only took 12. So in theory, you would say that these results prove that improved STD treatment reduces the incidence of HIV infection. Here's the reference if you want to check on who provided the consent. And if you say, well, once this has been proven, should people go out and improve STD diagnosis and treatment throughout sub-Saharan Africa? How many are in favor of that? Everybody's in favor of that. Has it happened? No, it hasn't happened. Why hasn't it happened? I think you probably know. It's called poverty and lack of interest and lack of attention and competing priorities and all those things. But in theory, this would have a profound impact on the risk of HIV transmission in poor communities around the world. Okay, so this is another sort of cute example. Again, we're back to diarrhea. And here, the question is, if any of you spent time in very poor communities, you may know that flies are a common problem. And people frequently see flies landing on their food, and they worry about whether that causes diarrhea. Do flies transmit the agents that cause diarrhea? When I first saw this study, I thought this was a really dumb study. Okay, so can flies transmit bacteria on their legs when they land on food? So they land on a pile of shit first, and then they move over to a pile of food. Can they move bacteria to the food? The answer is yes, they can. You won't be surprised to know. Okay? But for most of the viruses and bacteria and parasites that cause diarrhea, the infectious dose is so high that this doesn't strike me as very plausible. And for the things that have a very low infectious dose, they're not very common causes of diarrhea in these communities. So I thought this was a really dumb study. Okay, and I was completely wrong. But here the question is, does killing flies, does using insecticide to kill flies in a village reduce the risk of diarrhea in kids? Could I do this study at the individual level? Could I kill your flies and not her flies? It doesn't work so well, right? Flies are sort of a community level thing, and I can't just kill your flies, right? So it doesn't even make sense to talk about that. And so, and there's another cute aspect of this, but here they take 8 villages. This is when it was still safe to do work in Pakistan, I guess. And basically, they knew that there was seasonality to diarrhea, that it peaked at a certain time of the year. And these are households where there are lots of animals, lots of manure, lots of flies. Okay? And so they take 6 villages. We're down to 6 villages now, randomly assigned to Group A or Group B. Flies were controlled by spraying insecticide in Group A villages in 1995 and not in 1996, and in Group B villages in 1996 and not in 1995. So this is what you would call a crossover design. If I kill your flies this year, your flies will be back next year, right? So here you can actually do a crossover design. You can't do that with something like a health education message, but you can do it with something like killing flies. Okay? And then the question is, what are the rates of diarrhea in the communities when the flies are being killed compared to when they're not being killed? Right? And this crossover design is cute in terms of basically villages can serve as their own controls. They also monitored fly density. So here you can see they had the Group A villages were sprayed in 95, not in 96. Group B villages unsprayed in 95, sprayed in 96. They had control villages that didn't get any spraying. And here you can basically see that here's fly density, if you're interested in fly density. Here are incidents of diarrhea. And what they basically showed in this study was that it didn't matter which village you were in, if your flies got sprayed, your risk of diarrhea went down. Okay? So whichever villages got sprayed, their rate of diarrhea was less. Okay? Is sort of the long and short here. So now again, you can see we're down to 6 villages. It doesn't take hundreds and hundreds of units in a cluster randomized trial. Diarrhea is a common outcome. And here they were able to demonstrate an effect with just 6 villages. I don't want to get into the details of the data here. If you're interested, you can take a look at that. But they basically concluded that fly control can have a substantial impact on the rate of diarrhea disease in rural communities. Okay? Okay, just one last quick one, because this is work done by Leah Fernald here at the School of Public Health, so I thought I would highlight it. And Leah, as you know, is a wonderful nutritionist, and she's interested in questions about poverty and its relationship to health. Here are the research questions she did together with Paul Gertler, an economist. Do conditional cash transfers lead to improved nutritional status and behavior in children? This is the trendy thing, if you will, in issues about how to improve poor countries. Does just giving money to people help? And then the question is, help in what way, in terms of health or in terms of other outcomes? If you pay people to keep their kids in school, if you pay them to vaccinate their children, if you pay them to do things, is that a better strategy than billboards and urging and things like that? Just give them money. Okay? So here you can see the study that Leah did, and 500 communities in Mexico randomized to early enrollment or late enrollment in the Oportunidades program. So here it was judged ethically not reasonable to randomize half the communities to nothing, but because they had limited resources and couldn't start the program everywhere at the same time, they did what's called a stepped wedge design. So everybody is going to get the intervention, but they're not all going to get it at once. And you're going to introduce it in steps and be able to compare what happens in early introducers to what happens in late introducers during the time period before the late introducers get it. Okay? This is a very trendy thing in terms of studies, these stepped wedge designs. The outcomes they measured were physical growth, cognitive and language development, socio-emotional development, whatever that is. Again, showing all these communities, how they randomly assigned them. You can't read this. I apologize for that. But basically showing that the kids at baseline in the communities were very similar. And what they basically found was that, that for some of the nutritional things, there really was no difference. Height for age, for example, there was no difference. But for behavioral problems, they actually noted a substantial reduction in behavioral problems in the intervention communities. Okay? So they looked at many different outcomes. Some of them they found a difference, some of them they didn't. But just a sort of a very different type of cluster randomized study looking at very different types of behaviors and outcomes. And in fact, they also looked at whether these differences mattered in terms of whether there was maternal education, et cetera. So I don't want to get into the details about this study, but what they concluded was that early enrollment reduced behavioral problems for all kids, no difference between groups in terms of height for age, BMI for age, assessment scores for language, et cetera. And you can read the details if you're interested. Okay, so I just want to conclude by pointing out a couple of things. First of all, as I've already shown you, there are proper ways to do cluster randomized studies. They're not a secret. Nobody's keeping the plans in a safe somewhere. Okay, so the reason why people continue to do these things badly is a complete mystery to me. But a guy named Cornfield, a very famous statistician 50 years ago, 60 years ago, said randomization by cluster accompanied by analysis appropriate to randomization by individual is an exercise in self-deception. So in other words, if I take a city of 10,000 and another city of 10,000 and I randomize one to the intervention and one to the control and treat them as though I randomized 20,000 people, you will come up with the wrong answer. Okay? So don't do it. Don't be tempted to do it. Okay? When you ignore the clustering effect in the analysis from these types of interventions, you'll end up with artificially narrow confidence intervals, artificially extreme p-values, and an increased likelihood of spuriously significant findings and misleading conclusions. Okay? And furthermore, if the editors and reviewers know what they're doing, they'll reject your manuscript and they won't let you publish it, which is not good for your career. Okay? So there are right ways and wrong ways to do cluster randomized trials, and there are all of these statistical methods are readily available. If you're thinking about doing this type of study, the first question is, why are you randomizing groups instead of individuals? What is the reason? And typically there's more than one reason, but you should be able to state explicitly why you have chosen to randomize groups instead of individuals. Okay? Secondly, when you do the sample size or power calculations, you need to account for the between group variation. Okay? And fundamentally, what that leads to is an increase in the sample size. Because of the correlation within groups, you end up needing a bigger sample size than if you were randomizing individuals. Okay? You need to account for any between group variation in the analysis. So you have to measure the groups carefully at baseline, and if there are differences, you need to take that into account in the analysis. It's important to stratify or match on confounding factors. We'll talk about that in a few weeks. And then to look at the distribution of confounding factors by group and take them into account in the analyses. These are things we'll talk about in a few weeks when we talk about how to deal with confounding. Okay? So the take-home message here, many of you, I'm sure, will get involved in randomized trials in which communities or groups are the level of randomization. So just be aware that they are different and that there are correct methods for planning such studies, for calculating sample size, and for analyzing the results. Okay? So, any questions? So on Friday, Lisa Barcelos will be here talking about a quick introduction to why genetics and genetic susceptibility are important in epidemiology. There's a whole course on that, but Lisa will give you a brief introduction. And then next Monday, I think, we'll be beginning our discussion of observational study designs with cohort studies. And we're going to spend, I think, all of next week talking about cohort studies. Okay?